Hello, my name is Aaron, and this is my presentation on repetitive transcranial magnetic stimulation and its role in reducing the symptoms of post-traumatic stress disorder, or PTSD. PTSD is debilitating lifelong mental illness caused by an intense traumatic experience. It's defined by cue-related responses, or flashbacks, hyperarousal, and negative emotions. While often treatable with psychotherapy and medication, this is not effective in all patients. Tied to memory cues and fear, neurological research into PTSD focuses on the limbic system, particularly the amygdala and two regions of the prefrontal cortex. The ventral medial prefrontal cortex, VMPFC, and dorsolateral prefrontal cortex, DLPFC. The amygdala is the region of the brain associated with emotional responses, particularly fear and avoidance behavior in response to stimuli. PTSD patients are noted to have a lower threshold of amygdala excitation and therefore stronger responses to fear. The VMPFC is tied to extinction of fear responses, with the DLPFC involved with executive functioning, emotional regulation, and modulating both VMPFC and amygdala actions. Both of these regions are less active in those suffering from PTSD, leading to a lessened ability to regulate fear. In fact, the size of amygdala in comparison to the VMPFC and DLPFC is a predictive factor in the severity of PTSD symptoms. The functioning of these specific brain regions is key to understanding the construction of PTSD. Transcranial magnetic stimulation, or TMS, is a non-invasive brain stimulation technique utilizing magnetic fields to stimulate neurons. Stimulation is produced by generating a brief but intense magnetic field by running an electrical current through a magnetic coil. This allows for the firing of action potentials and the polarization or depolarization of brain neurons, albeit only in the brain regions beneath the skull that the coil can reach. In general, high-frequency stimulation of over 5 Hz excites, and low frequency of under 1 Hz inhibits neurons. These excitations and inhibitions allow for a wide array of effects, such as motor movement or brief lapses and flashes in vision. TMS also has improvements over transcranial electrical stimulation, as it is more easily able to bypass the skull and causes no pain to the patient. Repetitive firing of TMS, or RTMS, provides a variety of benefits to neuroscientists and neuropsychologists, as it allows for easier mapping of brain regions and their functions, as well as being able to be used as a therapeutic treatment. Why would RTMS be an effective treatment for PTSD? Well, RTMS is already used as a therapeutic intervention in patients suffering from depression and OCD. In addition, RTMS's ability to activate or inhibit regions in the brain seems quite promising as a way to mitigate the hyperactivity of the amygdala and alleviate the hypoactivity of the VMPFC and DLPFC. This would heavily improve patient outcomes by reducing the altercations in their brain chemistry, especially useful for those who find psychotherapeutic treatments unsuccessful. While being unable to reach subcortical regions like the VMPFC, TMS can be used on the DLPFC, and many argue exciting it will result in better treatment outcomes. Some argue that inhibition of the DLPFC would also be effective, however. Another debate exists between stimulating the right DLPFC or the left DLPFC, as site-specific effects have been noted in the treatment of other disorders, e.g. depression. That is a strong theoretical basis to argue that RTMS could alleviate PTSD symptoms, but does it hold up to scrutiny? There's an overall reduction in PTSD symptoms for patients who receive RTMS treatments in comparison to sham trials, making it an effective treatment. RTMS was also effective on patients who had experienced little positive change in psychotherapy, and effects were still observed 3 months after treatment. Small sample sizes and differences in applying RTMS make the effect size uncertain, however, especially when some trials utilize treatment alongside traditional SSRI prescriptions. There's a noted discrepancy between stimulating the left DLPFC and the right DLPFC, with right DLPFC treatment heavily reducing trauma and anxiety symptoms, while left DLPFC treatment slightly reduced trauma symptoms, heavily reduced depression scores, and had no effect on anxiety. The reason why anxiety symptoms reduce in right DLPFC treatment is likely because it improves function of the damaged prefrontal cortex, though it is speculated that polarization of the right DLPFC might also inhibit left side memory retrieval. Left DLPFC stimulation is frequently used in depression trials, so the fact that it affects PTSD-related depression is not surprising either. This makes the right DLPFC the clear better choice for treating PTSD. Likewise, high-frequency excitatory stimulation was more effective at reducing symptoms than low-frequency, though strangely, low-frequency also had a positive effect, while some speculate that because of the complexity of the brain's interlocking regions, inhibiting or exciting the DLPFC could result in different networks being polarized. Ultimately, there's not a clear consensus on why this occurs, some suggesting our knowledge of TMS could not be advanced enough. There's a variety of future opportunities for research to take. Most studies had small sample sizes, opening the door for a test with a much larger population. The fact that many patients were receiving traditional treatment at the same time, and the disputed comparison of HF versus LF, high frequency versus low frequency, suggests the need for more sophisticated tools for assessing outcomes and using TMS as a monotherapy. While patients who found therapy ineffective received positive results in TMS, it is unknown if TMS treatments are as effective in these patients, and that's worth exploring. Finally, most research fails to consider different subtypes of PTSD with slightly altered biological underpinnings, as the means by which PTSD is acquired is noted to alter symptoms. And that was my presentation. I hope you enjoyed it.